Hello everyone. Welcome back to this series of lectures in nephrology. This is Dr. Maitreyi. So today we will be learning about another very important topic, which is your cystic disorders of your kidney. So let's begin. So the first and the most important cystic disorder is your polycystic kidney disease, right? So there are two forms. We have your ADPKD, which is inherited in an autosomal dominant pattern, and you have your ARPKD, which is inherited in an autosomal recessive pattern. So what happens in this ADPKD? Let us look at that first. So ADPKD, as the name suggests, is inherited in an autosomal dominant pattern. Okay, so the genes that you have to remember are polycystin 1 gene and polycystin 2 gene. Okay, so the polycystin 1 gene is also known as a PKD1, which is present on chromosome number 16p. And the polycystin 2 gene is also called as PKD2, which is present on chromosome number 4q. So polycystin 1 on chromosome number 16p and polycystin 2 on chromosome number 4q. So what is the function of this polycystin gene? So the polycystin gene is basically responsible for the smooth functioning of the tubules and the cytoskeleton, right? So it is responsible for the smooth functioning of the tubules. So when that is affected, what happens is that there is accumulation of lot of mucinous material and cyst formation within the kidney. Okay, so the ciliary function as well as the tubular function is dependent on this polycystin genes. So how do you diagnose this polycystic kidney disease? So at the age of 15 to 39 years, if there are more than equal to 3 cysts in unilateral or bilateral kidneys. So at the age of 15 to 39 years, if there is more than equal to 3 cysts, then we call it polycystic kidney disease. At the age of 40 to 59 years, if there are more than 2 cysts in each kidney, and more than 60 years, more than 4 cysts in each kidney. So this is how you define polycystic kidney disease. So it's defined based on the number of cysts on the ultrasound examination. Alright, so clear till here. Now what are the various presentations with which polycystic kidney disease can present, right? So most of the time polycystic kidney disease is asymptomatic. So it is asymptomatic and it is picked up on routine examination. So somebody has gone for a routine checkup and they do an ultrasound and they find a polycystic kidney disease. Apart from this, because of the number of cysts, when the cysts increase in number, there can be associated renomegaly. Which can be picked up on your physical examination, and sometimes because of this renomegaly, they can also have some kind of an abdominal pain. Okay. Apart from that, sometimes they can also have hematuria. They can have recurrent infections as well. Okay. So they can be detected on routine screening that we have seen. What are the other causes for abdominal pain in your polycystic kidney disease? So other causes is 1. There is a tendency for stone formation. Uric acid stones more than calcium oxalate stones. So the presence of these stones itself can cause pain, mainly because of a renal colic. Second, the cyst itself can undergo rupture. The cyst can cause rupture and it can cause peritonitis, which can cause abdominal pain, right? The cyst can sometimes also have hemorrhagic fluid. So there can be cyst hemorrhage, which can also cause sudden severe abdominal pain. Then it can cause hypertension. It can cause nocturia and polyuria, right? So the cyst generally, polycystic kidney disease can have a tendency to form CKD. So the earliest sign of CKD would be nocturia and polyuria. They can have hematuria and you can have cyst infections as well. So cyst infections are also another very important complication for PCKD. So the most common organisms which are associated with cyst infection include E. coli and Klebsiella, right? So the antibiotics, there are only certain group of antibiotics which are useful and which can penetrate the cyst and help in clearing the infection. So this includes ciprofloxacin or Ciplox. This includes ciprofloxacin and cotrimoxazole. Right? So this includes ciprofloxacin and cotrimoxazole. So these are some of the few antibiotics which are able to penetrate the cyst. Right? So if a PCKD patient presents with UTI, then you have to consider a cyst infection. And if there is a cyst infection, there are only some antibiotics which penetrate the cyst, and hence you should be very careful in picking up which antibiotic you want to use to treat this patient. Okay. So this is your gross image. So you see that there are multiple cysts. The entire renal parenchyma is replaced by multiple cysts throughout the kidney. So there is complete destruction of the renal parenchyma. Okay, so what are the presentations? They can be asymptomatic, they can have abdominal pain because of renal colic, abdominal pain because of cyst hemorrhage or cyst rupture. Then you can have nocturia, polyuria, secondary hypertension. You can have hematuria and cyst infection. Okay, so these are the complications and various presentations of polycystic kidney disease. Now let us look at the associations. It's very, very important that you know the associations. In the brain, you can have associated saccular aneurysms. So a PCKD patient presents with severe headache. If a PCKD patient presents with severe headache, then you have to do an MRI brain to rule out these saccular aneurysms, because these aneurysms have a high chance of rupture and you can develop a subarachnoid hemorrhage. That is the reason why if a PCKD patient presents with severe headache, you have to do an MRI of the brain. Right? Apart from this, the most common extra-renal association is the presence of hepatic cysts. Then, in the heart, it's associated with mitral valve prolapse, and you can also have intestinal diverticulate. So these are the other associations for polycystic kidney disease. Now let us look at the management. So blood pressure management is very, very important. You give them ACE inhibitors or angiotensin receptor blockers. Also these are useful because they help in reducing the proteinuria also. Then water intake. Water intake should also be maintained. They should maintain a good urine output and you ensure that they have adequate fluid intake. Tolvaptan. Tolvaptan is a new drug which has been found to be efficient in the management of cysts in polycystic kidney disease, and it prevents the formation of new cysts in PCKD. So Tolvaptan has been found to be useful in PCKD. Right? But the final treatment would be if this PCKD patient goes on to end-stage renal disease, then you may have to plan a transplant. If they go on to CKD and they become anuric. So pre-transplant nephrectomy, when do you do? Pre-transplant, generally we do not do a nephrectomy. When do you do? If there is associated severe hypertension, or if there has been a cyst hemorrhage and bleeding, or there has been a severe infection or cyst infection, then you have to remove the kidney before replacing it. Okay. So this is about your management of polycystic kidney disease. Now let us look at some of the other cystic kidney disorders. So next is inherited cystic kidney disease, which is your autosomal recessive polycystic kidney disease. So the gene here is your PKHD gene on chromosome number 6. So what were the genes for autosomal dominant? It was your polycystin 1 and 2, PKD 1 and 2. Here it is your PKHD gene which is present on chromosome number 6. So autosomal recessive polycystic kidney disease generally has a more severe course and it presents much more earlier. So it can be associated with pulmonary hyperplasia and Potter's facies. So it has a 30% perinatal mortality. And it can be associated with congenital hepatic fibrosis as well. So ARPKD presents much more earlier in the neonatal period itself. It's associated with Caroli's syndrome, which is your congenital hepatic fibrosis, pulmonary hyperplasia, Potter's facies, and it has a 30% perinatal mortality. The next cystic kidney disease is your nephron of the cyst, which is because of an inherited defect in the nephrocystin protein. So how does nephron of the cyst present? It presents at the age of 5 to 8 years and it presents with salt wasting, polyuria and rickets. And they reach end-stage renal disease by 12 years of age. So nephron of the cyst is due to a defect in the nephrocystin protein. It presents in the age group of 5 to 8 years with salt wasting and polyuria rickets, and they reach end-stage renal disease by 12 years of age. Now there are certain syndromes with which this nephron of the cyst is associated, right? So if nephron of the cyst is associated with retinitis pigmentosa, if nephron of the cyst is associated with retinitis pigmentosa, it is called as Senior-Loken syndrome. Senior-Loken syndrome. It has some degree of mental retardation as well. If nephron of the cyst is associated with cerebellar hypoplasia, it's called as Joubert syndrome. It's called as Joubert syndrome. Okay. So the treatment for nephron of the cyst is also finally a renal transplant. Let us look at the next one, which is your medullary cystic kidney disease. So as the name suggests, medullary cystic kidney disease basically means that there are a lot of cysts in your medullary area. Okay. So this disease basically occurs at a little later stage and they have end-stage renal disease by 40 years of age. So the most common associations which are seen with medullary cystic kidney disease are insulin resistance and gout. So middle-aged, most often ladies who have insulin resistance, recurrent episodes of gout, and they go into end-stage renal disease by 40 years of age, you can have an associated medullary cystic kidney disease. The next is your medullary sponge kidney. So medullary sponge kidney is basically a little benign. Medullary sponge kidney basically has a relatively benign course, right? So it presents with this triad of symptoms of hematuria, recurrent stones and urinary tract infection. So it does not go into chronic kidney disease. It basically just presents with hematuria, recurrent UTI and recurrent stones. So you manage them more symptomatically and conservatively. Okay. So this brings us to the end of our discussion on cystic kidney disorders. We have learnt about autosomal dominant polycystic kidney disease, autosomal recessive. Then we have learnt about nephron of the cyst, medullary cystic kidney disease and medullary sponge kidney. Thank you.